Good day, all. We will continue our discussion on central nervous system meds with a focus on mood disorders and the medications used to treat them. Now, we ended an earlier lecture with a discussion on antiepileptics. This class of medication, which includes valproic acid and carbamazepine, can also be used to treat bipolar disorder. So I thought that we would start there. Bipolar disorder is a common but very serious mood disorder where a person can experience feelings of intense euphoria and then deep depression. Some will experience a milder form of the euphoria known as hypomania. Still others can experience the mania and depression at the same time, but most will cycle between the two moods. The pathophysiology of bipolar disorder isn't fully understood, but is thought to involve excess levels in the brain of excitatory neurotransmitters such as norepinephrine or glutamate. In fact, serum and urine samples collected from clients experiencing mania can have very high levels of catecholamines. Another possible neurotransmitter imbalance is thought to cause the illness is a deficiency of GABA. Since antiepileptics enhance the action of GABA, they are often a good choice for treatment of mania as well as a maintenance treatment. On the next slide, I'm going to play a video of a woman experiencing a manic episode. As you watch the video, write down some of the symptoms that you see. We will compare notes, and I will give you some of the medical terms used to describe the behaviors.
Hello, hi. Okay, so as you guys could tell by the title, this is a video in which I show you guys myself having a manic episode. So obviously, like right now, I'm not like super duper crazy manic where I'm having like a crazy episode. I'm just almost normal right now, but a little while ago, like it was nighttime, and I got really manic, and I thought to myself that I had this genius realization that the One Direction song Stockholm Syndrome just perfectly describes mania, and I needed to just like write it down, and my hands were shaking really hard. So instead, I just decided to record myself just in the middle of the night, like super manic, and I rewatched that recording, and I was just like, yikes. But I know a lot of people don't really know what mania is like, or like they're curious about what it's like to have like a manic episode, and this isn't like the worst episode that I've had by any means. Like worst episode, I cut off my hair. One of the worst episodes. I actually overdosed in another bad episode. So yeah, this is definitely not the worst, but I think just like the way I'm talking and like how my attention span is very short, and like things that I'm saying aren't making any sense, and I think that's all like overall like a good representation of mania. So yeah, I'm just gonna insert the clip right here so you guys can see for yourself, and I can stop talking about it. I don't know why I'm describing it when you can just see it. Baby, look what you've done. I've come to a genius realization. Okay. Okay. Just needed to move. I don't know why I needed to move. I'm gonna sit down. Sit on the floor. Okay. Okay, so I just came to a real. So I was shuffle playing my music. Okay, I was just shuffle playing it. Like anything could come on. I don't know what's gonna come on. And then put you down right here. Okay, am I gonna put you down? I don't know how to put you down. Just stay. Just stay somewhere, phone. Okay, let's put you here. Let's see if you stay. You stayed. Okay, so I don't like this here because I can see the mess and just. Shit. You fell. Are you okay? Okay, so I'm going to go over here to this side of the floor. Okay, so I just had this genius realization, and I was just like, I need to just tell myself. Okay, so Stockholm Syndrome by One Direction is the perfect depiction of mania. Like, everything about that song, like, even from the beginning, like, I don't remember what the beginning is, but I just, and then they're like, I know they'll be coming to find me soon because eventually someone's gonna get me and someone's gonna be like, get better and like stop this and like whatever. Like, hey, like you're just, or just I'll be like that, or like I felt like someone was in my house the other day, and so I was just, yeah, but whatever. So then that's when it gets too much, and it's too much, and it's too much for anyone, right? But like now, it's just like it feels like my entire body is like being tickled. What a thing to say. What a weird thing to say. No, but like really, like I just feel like my entire body is like wired up. Like there's just so much energy, like all the way from like my head to my toe, and I'm on 700 milligrams of Seroquel a day, so I shouldn't feel this much, but I'm feeling so much and it feels so good, and I don't want it to stop. And I just feel like the Stockholm Syndrome song by One Direction just really, really exemplifies what mania is like. So I need to like, I don't want to make another video about like bipolar disorder because I feel like I'm just exploiting it for views, which is like whatever. Like, yeah, I guess like why not? Hey, like make the best out of the situation, right? Because like this kind of sucks, but also this doesn't suck, and I feel so good, and I like feel so bad for people that can't feel what I'm feeling right now. Oh my god, like the floor is so nice. Like the floor is so good. The floor is just wonderful. Yeah, I just, oh my god. So one time I wanted to make candles, and I just like I couldn't make candles. And I picked up knitting needles. Oh my god, if I was a superhero, I feel like I could be like someone that wears a cardigan, because I really love cardigans. My mom bought me 3 new cardigans today. That was fun. But I could wear cardigans, and I could have knitting needles, and I could just pull out the knitting needles. Oh my god, I think that was like a villain in Word Girl. I think I just stole that entire concept up from PBS Kids. So don't even listen to me. I'm being a plagiarizing whore. Why did I start recording? I had a very specific reason. Oh yeah, Stockholm Syndrome. I just needed to like write down this like the revolution, but like I opened up my notes, and then I caught it. My fingers were just shaking too much, and I figured, hey, like I could record. Oh my god, I dropped the ponytail. What? Um. Yeah. So I just yeah, I don't remember what I was going with this. I guess like I should stop recording, because then I'm gonna look back at this and be like, what were you thinking about? Like, you're so stupid. Me to me. That's not a compliment, so that wasn't funny, but whatever. I'm actually really funny, I think. I think I'm hilarious, but you know, you gotta have a specific sense of humor. Okay, yeah, I'll stop now. And that was it. It wasn't the longest clip. I wasn't also making any sense, but whatever, like that was that. So if you guys enjoyed it, please, well, if you guys enjoyed me watching me have a manic, that's a weird thing to say, I realize now. But if you guys would like more content from me, thumbs up, maybe subscribe. Of course, I'm going to give this disclaimer, and not disclaimer, I'm just going to say this as I do in every single video that I ever make. I have a book, and it's about mental issues and identity and love and all that stuff. It's called I Love You. It's on Amazon now. It's also available for free on Smashwords, so if you guys would like to read it, I will link it in the description below. It is much more, like, I'm a much better writer than I am like a speaker, so I can really like, I feel like illustrate what mania, what depression, what all of that stuff is like, and just how to cope with it, or at least how I cope with it. And yeah, so give that book a read if you're interested. Anyway, yeah, this is it. Hope you guys enjoyed, and I will talk to you next time.
Let's see what you came up with. Subject of the video spoke several times about a genius realization, and this is indicative of inflated self-esteem, the thought that one's ideas are superior. Instead of sleeping, she was making videos in the middle of the night. Sleep disturbances can occur. She was also easily distracted and went off on tangents as she spoke. Speak about the floor and the knitting needles that she'd pull out of her head. And this is called flight of ideas, where one thought leads tangentially to others. Even during the beginning of the video, where the subject was hypomanic, she couldn't sit still. She fussed with her hair. Her arm and hand movements were exaggerated. She experienced psychomotor agitation. Her speech was forceful and rapid, and that's referred to as pressured speech. Other manifestations could include impulsive behavior. This would include inappropriate sexual relationships, shopping sprees, extravagant spending, often maxing out credit cards. In severe cases, psychotic behavior could occur. When these symptoms occur for more than 1 week, the person is diagnosed with bipolar disorder. The traditional drug of choice for treatment of bipolar disorder is lithium, whose pharmacologic class is an ion salt. Its mechanism of action is uncertain, but it might possibly affect the transport of sodium in nerve cells. As a result, norepinephrine production, an excitatory neurotransmitter, is altered. Lithium is also thought to increase the production of serotonin, so this medication has an antidepressant effect as well. We'll talk about serotonin's responsibility in maintaining mood a little later. Lithium is sometimes used by itself, what we call monotherapy, and sometimes with other medications that treat bipolar disorder, like the antiepileptics I mentioned before. There might also be the need for meds that treat this complex disease, such as antipsychotics and anti-anxiety meds. Antidepressants are not usually given while the person is manic, since they can exacerbate the mania. However, they could be given when the mania subsides in order to treat the depression associated with the condition. The dose of lithium that is given is based on serum levels. Lithium has a very narrow therapeutic range, 0.6 to 1.2 milliequivalents per liter. This narrow range means there is a risk of toxicity. One of the reasons it isn't as widely used as it used to be. The initial dose is given and then increased in 10 days if there is no improvement. At this time, we will carefully monitor the client's serum lithium levels. Common side effects of lithium that can occur when starting the med are muscle weakness, tremors, polyuria, thirst, nausea, and confusion. These generally disappear or are easy to manage. Still, clients do need to report these symptoms to their provider. Potentially serious, even fatal events can occur with lithium toxicity. Toxicity can occur with the use of diuretics, which increase the concentration of serum lithium by hastening the excretion of water and causing dehydration, or When the client limits salt intake, limiting sodium intake can result in a buildup of lithium levels and result in toxicity. There are also several other meds listed on this slide that increase serum lithium levels. Lithium also has serious adverse effects with long-term use. Cardiac dysrhythmias would be the most serious, but renal failure, diabetes insipidus, and hypothyroidism may occur. So we need to assess for these conditions in those clients taking lithium for maintenance therapy. We're going to shift our focus now to depression. Same as before, I'll show a video. You write down symptoms, we'll compare notes, I'll give you some medical terms.
I didn't want to face anyone. I didn't want to talk to anyone. I didn't really want to do anything for myself because I felt like I was such an awful person that there was no real reason for me to do anything for myself.
Depression is more than just a feeling of being down in the dumps or blue for a few days. It is a serious illness that affects many people. Symptoms can vary, but many depressed people lose interest in activities they normally enjoyed, have feelings of sadness, guilt, and worthlessness, and have trouble concentrating.
Couldn't sit down for a minute really to do anything that took deep concentration. I tried to journal and I tried to do things, but I couldn't do that. I didn't read a book, didn't really do. I barely went to class. I wouldn't get out of the house. I was in college, so I wouldn't go to classes at all. I gained a lot of weight.
A person with depression can feel irritable and restless and have sleep problems.
Sometimes I'd sleep like only 3 hours a night because I couldn't sleep for weeks, but most of the time the opposite happened where I would sleep 10, 12, 15 hours a day even.
People who are depressed can feel numb and tired all the time. In some cases, it can even lead to thoughts of suicide.
It was like I had big, huge weights on my legs and I was trying to swim and it just kept sinking. And I'd get a little bit of air just enough to survive, then I'd go back down again. It was just constantly just fighting.
Depression is a real and complex illness that is not yet completely understood. We do know that the brains of people with depression are different from those without the illness, but we aren't sure why. Scientists at the National Institute of Mental Health are studying brain images of people who suffer from depression, trying to learn why it affects some people but not others. Treatments for depression do work. One type of effective psychotherapy is called cognitive behavioral therapy, or CBT. CBT can help you change ways of thinking and behaving that may be damaging or contribute to depression.
I had one really good therapist, and through her I think I started really thinking about that I did have depression.
Medications called antidepressants can also help. NIMH researchers are getting closer to figuring out exactly how these medications work, who benefits from them the most, and how to make better, more effective ones. For many people, a combination of medication and psychotherapy may be the best choice. Depression can be successfully treated in many people, but sometimes treatments fall short. For this reason, NIMH continues to study the genetic, biological, and environmental factors that influence depression so that new and better treatments can be developed.
Other people, it became easier. I totally think it is a lot easier when people know. I think that was one of the key things that helped me do it, so that I wasn't doing it all alone.
If you have depression, telling friends, family, or someone you trust, and finding a doctor or therapist are the first steps on the road to recovery. Depression treatment can take time to work, so don't give up. Read more about depression on this webpage. If the symptoms fit, get help now.
Let's compare notes. To me, two early comments really stand out. I didn't want to face anyone. Clients experience social isolation. I was such an awful person. Lack of self-worth, feelings of guilt. The gentleman talked about sleep disturbances, maybe too much, maybe too little. In addition, clients experience loss of pleasure in things that they had found pleasurable before, what we call anhedonia. Psychomotor retardation, a slowing of responses, of movements can occur. The client also complained that he put on a lot of weight. Changes in eating habits can occur. Now, even though this gentleman put on weight, people can lose weight as well when they stop eating. An inability to concentrate, and thoughts of suicide. 5 of these symptoms, experienced every day for 2 weeks, represents a major depressive disorder. We all experience sadness at some point in our lives. Sadness in response to a life event like loss of a job or perhaps a poor grade on an exam. Depression is different. The sadness is persistent, extends for longer periods of time, and functioning is impaired. The pathophysiology of depression is not completely understood, but it is likely caused by low levels of the neurotransmitters serotonin, norepinephrine, and dopamine. When these imbalances occur in part of the brain called the limbic system, depression occurs. The limbic system is that part of the brain that regulates mood. There are other factors that are connected with depression, and these would include hormonal, genetic, and environmental factors. Before a diagnosis of depression is made, other possible causes are ruled out. These conditions might include medications like steroids, oral contraceptives, anti-Parkinson's meds, and antipsychotics. They might also include abuse of drugs and alcohol, and physical conditions such as vitamin B deficiencies and hypothyroidism. Treatment of depression involves not only pharmacotherapy, but psychotherapy as well, where patients are helped to change negative thinking and change behaviors that feed into the depression. Selective serotonin reuptake inhibitors, or SSRIs, are the pharmacologic choice of antidepressant that is most widely prescribed. They have a favorable side effect profile, which means side effects are less severe than other types of antidepressants, and they have demonstrated effectiveness. SSRIs prevent serotonin from re-entering the presynaptic neuron. More serotonin remains in the synaptic gap, so it is available to bind to serotonin receptor sites and exert an enhanced effect on mood. SSRIs are used for other conditions as well: obsessive compulsive disorder, bulimia nervosa, and the depression that accompanies bipolar disorder. These medications should not be given during periods of mania, since SSRIs can exacerbate the mania. The most common side effects of SSRIs affect the GI system: nausea and vomiting. These side effects generally stop in a few weeks, There's sometimes a temporary agitation. Again, this is a side effect that will eventually clear up. Taking the medication with food can help to offset the agitation. Either weight gain or weight loss can occur, so the patient's weight should be monitored throughout therapy. Remind your patient that effects may not be felt for 2 or 4 weeks and to continue to take the medication. Also, inform the client to take the SSRI even when mood improves. There is an increased risk of relapse in clients that stop taking their antidepressants. Another important point, as the mood lifts, the risk of suicidal thoughts increase. Assess your client's mood throughout therapy. Serotonin syndrome is a dangerous condition that occurs when the client takes other SSRIs or antidepressants along with their prescribed SSRI. It can also occur when taking an SSRI along with St. John's wort or street drugs like ecstasy or LSD. It is characterized by hyperactivity, neuromuscular changes, and mental status changes, but can lead to high fever, seizures, and death. Treatment involves periactin, which inhibits the production of serotonin. Another class of medications are the tricyclic antidepressants, or TCAs. These would include medications like amitriptyline and imipramine. This class of medication interferes with the reuptake of both serotonin and norepinephrine into the presynaptic neuron. Therefore, there are increased amounts of norepinephrine and serotonin to help improve mood. The TCAs block muscarinic receptors in the parasympathetic pathway, and this action accounts for anticholinergic side effects. These side effects include dry mouth, constipation, blurred vision, and orthostatic hypotension, which increases the risk for falls. TCAs also block histamine 1 receptors in the central nervous system, so sedation can occur. Same as with SSRIs, clients might not feel the effects for several weeks, and they should continue to take the meds even if their mood has improved. TCAs can worsen Parkinson's disease, seizure disorders, and cardiac dysrhythmias. One very important note here. Overdoses with TCAs can lead to seizures and dysrhythmias and have greater potential to be lethal. As with other antidepressants, continue to assess the client's mood throughout therapy. Monoamine oxidase inhibitors were the first class of antidepressants that were developed. They inhibit the action of an enzyme called monoamine oxidase, which breaks down norepinephrine, dopamine, and serotonin. When these neurotransmitters are prevented from breaking down, there are more of them available to help improve mood. Unfortunately, they have a long list of drug-drug and food-drug interactions, as well as several adverse effects. So MAO inhibitors are used only if other classes of antidepressants are ineffective. The most serious adverse effect is hypertensive crisis, which can occur when clients take MAO inhibitors and eat foods high in tyramines. Tyramines are precursors to catecholamines and can increase norepinephrine production to dangerous levels. Remember from our discussion on the sympathetic nervous system that norepinephrine has a vasoconstrictive effect. Taking MAO inhibitors and tyramine-rich foods can induce extreme hypertension that can be life-threatening. A list of tyramine-rich foods is included on the next slide. I'd like to finish by reminding you of your responsibilities as an RN when your client is taking an antidepressant. Teach them about the therapeutic and expected adverse effects. Encourage them to continue to take the med, even if feeling better. Inform them that it may take several weeks for the changes to occur. Assess mood, weight, and health status throughout medication therapy. Provide emotional support and encourage expression of their feelings, both positive and negative. Finally, suggest participation in support groups. We'll meet again at the next lecture. Take care.